So hi all, my name is Dr. Leah Upton. I'm a family medicine physician, and I'm also the medical director at Community Health Connection. We're a federally qualified health center in Tulsa, Oklahoma. And CHC is so proud to be connected with Matriarch and to be working with all of you who are working to improve health outcomes for Oklahoma women and families. Your attendance at Lady Chart today says a lot about you. It says that you understand that the inequities in health outcomes for Oklahoma women and families are real, and that they must be reckoned with, especially those that relate to racial disparities. So in 2020, Tulsa launched its first dedicated birth equity organization, the Tulsa Birth Equity Initiative, who presented a workshop at this conference. And their work is helping to erase the disparities in health outcomes that we see in our moms and babies by creating the first community doula program in Tulsa. Tulsa Birth Equity Initiative, thankfully, is not alone. Whether you work in advocacy or clinical services or data management, it's likely that your organization also has a strategic priority that is built around advancing health equity for Oklahoma women. With our collective power and our singular purpose around this goal, we are changing the world. But how did we get here? How did we broaden our thinking and arrive at this priority? Well, the answer has a lot to do with the work of our closing keynote speaker, Dr. Joia Crear-Perry. Dr. Joia Crear-Perry is a thought leader in the area of racism as a root cause of health inequities. She is a respected speaker, trainer, advocate, policy expert, and fighter for justice. She also is the founder and president of the National Birth Equity Collaborative. Recently, she addressed the United Nations Office of the High Commissioner for Human Rights to urge a human rights framework to improve maternal mortality. Previously, she served as the executive director of the Birthing Project, director of Women's and Children's Services at Jefferson Community Healthcare Center, and as the director of clinical services for the City of New Orleans Health Department. There, she was responsible for 4 facilities that provided health care to the homeless, as well as pediatric, gynecologic, and WIC services within the New Orleans Clinical Service area. Dr. Crear-Perry has been celebrated for her work to improve the availability and utilization of affordable healthcare for New Orleans citizens, especially after the Hurricane Katrina disaster of 2005. Currently, her focus has expanded nationally and internationally as it relates to maternal child health. Joia is a proud recipient of the Congressional Black Caucus Healthcare Heroes Award and the Maternal Health Task Force at Harvard University Global Visionary Award for commitment to advancing women's health. And she's best known for her work to remove race as a risk factor for illness, like premature birth. She's a sought-after speaker, as well as an educator in the field of maternal child health, and has had articles, many articles in a number of magazines, including Essence, Miss Magazine, and publications around structural racism that have had wide impact. So Lady Charts 2021, I present to you, Dr. Joia Crear-Perry.
Thank you so much, Leah. I appreciate that. Hey, y'all. How Tulsa? How y'all doing? So I'm in between you and dinner, I bet, right? So thank y'all so much. We got some good yoga. I'm feeling relaxed. I don't know about you, but I feel better. So hopefully we can have someone to put our thinking time on. I am not the best at technology, so the lovely Brandy will be assisting me with the advancing of the slides. And hopefully we can, have a good conversation together. Okay, so here we go. Great. So we're going to talk about how we can use data for truth telling when it comes to birth equity. And birth equity includes everything from infertility, contraception, abortion, and maternal and child health to cancer, anything that has to do with our reproductive parts, that's included in our work around birth equity. Next slide, please. Right, so our organization is almost 6 years old. Time flies when you're having fun. We were started with funding from the W.K. Kellogg Foundation to work on Black infant mortality, because although I am a almost 50-year-old Black woman in a 49-year-old Black woman's body, like many of you, we focus so much on babies and we ignore the wrapper, the candy, the baby, and the wrapper around the baby, the mommy, we don't invest a lot of money or time or energy into. We added maternal health to our mission and vision. And recently we looked at our core values. The one that I would like to uplift today is freedom. Because places like Tulsa have shown us that when you fight for freedom, when you fight for um, truth and racial healing, when you have a community that comes together to really acknowledge what's happened in the past to go to a better future, you can provide for a better future for everyone. Next slide, please. So these are our objectives. When you're a physician, you do a lot of grand rounds and do a lot of talks. And you have to make sure we have objectives. So we'll get through these today. Next slide, please. So this really is an important slide for me and for all of us to really think about this work and to level set us as we start this conversation. Because often we think if we could just get one webinar or one rapid cycle conversation, or we could come together, we can fix everything. Well, recognize that 86% of the Black experience in the United States of America has been legal oppression by law. Things like not only chattel slavery, but segregation, mass incarceration, police violence that still continue today. So it's not going to be fixed with this one webinar. This is just the beginning of a conversation. It's not going to be fixed with a few policy changes or even the important work that doulas and midwives do in the community. It's going to require all of us to look at all the ways that not just the policies upheld this 86% of our time being under explicit racial oppression, but really the cultural belief in a hierarchy of human value based upon skin color. That's what we have to undo, this belief that there's something broken about Black people. That's how we get to justice and joy. Next slide, please. So as was mentioned, I was honored and privileged to fly to Geneva and present to the UN. I've testified I'm from Louisiana, so in New Orleans in front of the city council, or in Baton Rouge in front of the state house, and even in front of Congress a few times at this point. But really being in Geneva at the UN was very humbling for me as a Black woman, because it makes you realize a few things. Number one, the United States is the only high-income country that does not operate out of a human rights framework. Many of you are really familiar with the civil rights movement, right? So in civil rights, we're all fighting for just the rights to be seen by law. So for Black people, the right to vote, the right to desegregate schools, for women, the ability to vote, for LGBTQ community, the ability to be married, right? But in other countries that have as much wealth as we do, they believe that just by virtue of you being born, you should have all these rights. You should be able to be fully capable to live to your full potential. So they do things in these other countries like free college, free childcare, paid leave, not just for maternity leave, paternity leave. So when we talk about the ways to improve maternal health outcomes, recognize that we will not fix it inside of a healthcare system or with OBGYNs fixing hemorrhage, right? Because that's just one small part of why we have the worst rates in the entire industrialized world. Every other country has invested in people, right? In their social needs, in the social safety net. They have a human rights standard. They believe that health is a right, that education is a right, and they invest in everyone equally. What would be really transformative for us, especially right now in this country, to show that a very diverse nation like the United States, diverse when it comes to race, religion, ethnicity, language, gender, that we can believe that all people are equal in a diverse context. And that's what's going to be the future of this country. Next slide. About 25 years ago, there was an election happening about like now, and there's a lot of talk about reproductive rights. So as OBGYNs and as many of you who are out there practicing, you might be providing reproductive health care services. As Dr. Upton mentioned, she works at a FQHC. I used to work at FQHCs and provide GYN services and run them. And so when you're a reproductive health, that means you do things like pap smears, you provide contraception, you can do abortions, you can do any of the things that for healthcare services. Reproductive rights are the laws that dictate how we're able to do that. So those are the policies. There can be big laws like having access to contraception in your community, or it could be small laws like your ability, how you allow for sex ed to be taught. Well, that's not really small, it's important too. The laws around how we teach sex ed and who teaches it and what do we include in that, right? So those are reproductive rights. The reproductive justice says that we understand that there was a time that there was a right to own Black people, right? So just because something's a policy doesn't mean that it's just. Just because something is a law doesn't mean that it's something that we should all aspire to or want to have. So reproductive justice says we have the right to human right to maintain personal bodily autonomy. So what that means is in our work, if a patient does not want a LARC, she doesn't have to have a LARC. If she wants to have as many children, if she wants to have 8 kids, she can have 8 kids. I have 3. And when they're all here together, I feel like the little old lady who lives in a shoe, but I don't get to judge other people. I don't get to make their choices for them. As many kids as they want to have, they can have. My job is to support them so they can have well being or to not have children. So many times we only value birthing people only when they're pregnant. The minute the baby comes out, we take away their insurance coverage. We don't care if they have access to a ride to get back to the doctor. They don't have support, right? So who do we value? And there are people who will never have, who have no desire to have children. So they're not valuable just because they don't utilize their uterus to give birth, right? So you are valuable even if you never have a child. And then this last one is really important. As a Black mother, especially in this moment with the murder of George Floyd and Breonna Taylor, and the world really grappling with undoing 500 years of a devaluation of human beings based upon skin color, we would like to parent our children in safe and sustainable communities. So that means if I show up at your march for pro choice, you show up for my Black Lives Matter march as well, because our destinies are tied. I worry about, as a Black mother, outliving my children. So my reproduction does not just end when the baby is born. I have a 10-year-old son who I do not allow to play outside with a toy gun. Like Tamir Rice's mother, I worry about someone seeing him as an adult and shooting him. And so I don't have to live like that. You should want me not to have to worry about my son playing outside. You should want me to be able to live in a space, and all Black people to live in a space where their children can just be seen as children. So until we can have the right to parent our children in safe and sustainable communities, then we will not have reproductive justice. Next slide, please. So it's important for us to think about under what world did we pick these measurements, right? What is an indicator? Indicator is a measurement. An indicator is a data point, and it's limited by our current reality. It's a product of our past understanding of public health and science, and systems are more apt to adhere to specific prescribed indicators than to determine alternatives. For example, marital status. We love saying single Black female, right? I'm married. My husband's super cute. But me marrying him, the act of marriage is not what improves my maternal and child health outcomes. Now, if he has wealth, right, or if I have a dowry, then that's great being married because that's what you're actually measuring is wealth and income. But if two poor people who are disenfranchised and been denied generational wealth just get married, that's not going to improve their health outcomes. And also, if you're married and you don't have social support and social safety, that's not improving your health outcomes. And you could have those things without being married. You can have a partner or a relationship or live in a home where you have all the social support and safety and wealth that you need. So why do we keep measuring marital status? What is that a measurement of, and under what framework do we choose that? Pregnancy intention, that's another indicator we love tracking. We measure it for everything from preterm birth to pregnancy to access to contraception. I intend to do lots of things. I intend to run a marathon. That requires me to one day actually, jog a little bit, right? So this idea that we ask people their intentions, we want people to have middle class intentions without investing in any kind of middle class money. They don't have access to higher education, to good schools, to good jobs, but you should intend to know better, right? That's once again blaming and shaming patients. So under what framework did we decide that the things that we should measure for good outcomes are marital status and your intentions? If you just get married and intend to do better, the rest of your life will all be perfect, right? And so a framework is a vision. It expands our understanding of our current reality. It allows us to think of new indicators. We've only been using pregnancy intention for 50 years. We could stop. We can decide it was based upon racism, patriarchy, and eugenics, and we could stop because it was. I have a whole lecture on the history of pregnancy intention in the framework. We can explore new alternative to traditional data collection and application. And we all of us, must question our historical construction of our health system, our non-health system, right? Like I mentioned, we're the only high-income country that has not agreed that health is a right. We're the only ones. We're an outlier. Why have we decided to have a healthcare system that does not invest in everyone, that does not believe everyone has the right to thrive? Right. And I would argue that human rights, reproductive justice, and birth equity are all frameworks. They're all frameworks under which you could choose new indicators. You can pick new things to measure because the current things that we're currently measuring don't get us to reproductive justice. They don't get us to human rights, and they definitely don't get us to birth equity. So what new indicators, what new language are we going to explore together so that we can create that vision of birth equity for all? Next slide, please. So birth equity is the assurance of the conditions of optimal birth for all people with a willingness to address racial and social inequities in a sustained effort. So now the American College of Family Physicians uses this definition. So does March of Dimes. We really looked at what are some definitions around health equity, equity in general. A lot of them talk about equity as a place. We're going to get to this place. We're going to hold hands, sing kumbaya. Everything will be great and the world will be perfect. We recognize that the same people who are today hoarding power and wealth are teaching their grandchildren how to hoard power and wealth. So we have to teach our grandchildren how to fight for justice and joy. So for us to do that, we have to put the conditions. That means the policies in place for optimal births. We don't want people to in Tulsa to survive a birth and say, oh, thank God I made it out of there, right? How do they live their best lives? How do we get to thrive? That means we have to be willing to address both racial and social inequities in a sustained effort. So a 2-year grant, even a 5-year grant, is not going to fix that first slide of 400 years of inequities. It's going to require all of us to have lifelong learning to undo the racism and the gender oppression and classism in our healthcare and our health system. Next slide, please. So pregnancy well-being, instead of intention, instead of saying stay poor, but just intend to do better and have this lark, right? What would it look like if we believed every person, no matter how many children they've had, no matter their religion, no matter their income, no matter their geography, that they all had the right to pregnancy well-being, right? So rooted in reproductive justice, pregnancy well-being asserts that regardless of access to knowledge, we love saying, if only they just knew better. What if they don't know better? Do we have no obligation to patients that don't have health literacy, right? So regardless of the access to health literacy, their access to power or money, that all birthing people are supported. That's our role as a system, as a community, as a healthcare provider. Our role is to support them, government and health systems, so they can be both physically and mentally well, right? When do we ever talk about pregnancy, depression, postpartum anxiety? People are anxious. That's the most common mental health condition. We're all nervous because we don't have the social supports that we need after we have a baby, right? So how do we support that? Next slide, please. Oops, sorry, one more back. It looks the same. Reproductive well-being is similar. This is the Power to Decide's definition. Their original name was the Campaign to End Teen and Unwanted Pregnancy. And they did a whole refresh. They looked and thought, wow, that's really blaming and shaming teen mothers. What is it really we want to say? We want people to have the power to decide. Not that they had a plan and that we have to have a campaign to tell them what they shouldn't be doing. We have to help build capacity and power within folks. And so that means that we believe in reproductive well-being, that all people have the information, services, and support they need to have control of their own bodies and to make their own decisions related to sexuality, because they might not ever reproduce, but most of us do at some point have some sexuality, and reproduction throughout their lives. So how do we ensure that everybody has the power to decide? Next slide, please. So what are the root causes? How do we get here? What happened? Next slide, please. So back in 2005, I was the director of maternal and child health for the New Orleans City Health Department. And y'all remember what was happening in 2005, right? It's a big storm. The president flew by and waved at us from his airplane from Air Force One. But the WHO, the World Health Organization, actually came to New Orleans and they sat in a hotel. And I was the young person in the room taking notes and being mesmerized by all these smart people from around the world. And they were talking about this idea that it wasn't just your genes or your choices that cause health disparities, but there's something called social determinants of health. Things like having a living wage, having fresh fruits and vegetables, having a job with paid leave, that those determine your health outcomes. Can you push it again, please? And that's what caused unhealthy behaviors and psychosocial stress. Push it one more time. And that's why we have disparities in the distribution of disease, illness, and well-being. So it's not because Black people have different kidneys or pelvises or lungs, or we make bad choices as a people universally, right? It's because of these social determinants of health. We have childhood obesity, not because children just like Chewies, although I personally like Chewies. We have childhood obesity because we've taken out physical education from schools. We don't have access to fresh fruits and vegetables in neighborhoods. Kids don't have an opportunity to run around outside and play, right? So that is causing unhealthy behaviors and causing a disparity in the distribution of disease, illness, and well-being. But you see, the top of my slide is still empty because although we've been having this conversation about social determinants since 2005, we haven't had the conversation about the root causes. Where do these social determinants come from, right? Why do Black people have lower rates of job security or a living wage? That's been left, that's been blank. Push it again, please. And one more time. And that's because we have a power and wealth imbalance. Push it again. And those are things like our labor markets, our education systems, our social safety net, our tax policy. So I'll pick on my own city of New Orleans again. After Hurricane Katrina, 80% of the city flooded. So of course, real estate developers came to the city. It's a great time to make a lot of money. They tore down low-income housing and built mixed-income housing. So they get a tax credit for creating mixed-income housing. So they get to tear it down. They make money from that. They make money from the rebuild. They make money from the tax credit. And then they need to have at least 7% of the people who live in the property be low income. So you've gotten rid of entire thousands of homes and replaced it with a mixed income, and you only need about 7% of those people to be low income. And then they only have to be in the home, in the apartment, in the condo for 10 years. So what do you think happened in 2015? All the poor people got kicked out. So they made money again because they could increase the rates and get rid of all the low income people for this tax break. That is a power and wealth imbalance. No one on this call would create a policy that says we're going to tear down people's houses, kick them out, raise the rents, and we don't really even care where they move to, right? That causes social determinants of health inequities. Push it again, please. In the US, it has three main root causes. One more time. And that is racism, classism, and gender oppression. You could add some more. I mean, you could add, especially in my own home state of Louisiana, you could add religious fundamentalism. You could add, in other contexts, tribalism. You could add casteism. But the truth is, until we undo the actual root causes, push it last time, we will continue to see these social determinants of health inequities. And if we only focus on the social determinants of health, we're never going to close the gap and reach birth equity. An example of this would be transportation. We interview Black birthing people across the United States about their experience of health and healthcare having a baby. Almost ubiquitously, they always complain about transportation. In urban America, suburban America, rural America, we have never invested in a transportation system in this country. It's the legacy and history of redlining, of Jim Crow, of the Green Book, of Black folks not being able to move freely about the country in general, but we don't have a transportation system. So if you're working on social determinants of health, what you would say is, man, this transportation is a mess. Let's make sure all of our patients have access to Uber and Lyft vouchers. And that's exciting because at least you acknowledge that they're not coming to their doctor's appointment, not because they just don't want to show up, but because there's actually a barrier for them receiving care. But if you're really going to work on the root cause, you would do things like ensure that there's high-speed rail, that we have access to buses, that there's transportation equity for all people in your community. That's how you decrease and get rid of the root causes of segregation and racism that are embedded and baked in all of our systems across the country. Next slide, please. So the social determinants of health are the conditions in which we are born, grow, live, work, and age. This is from WHO from 2006. Most people can quote that first sentence, but they don't. It's like the preamble to the Constitution. They only say that first sentence. We don't say the second part. We haven't talked about where it shows up, right? Like I've always lived in Black neighborhoods, not just because it's tribal and I see Black people and I just want to live near some Black people, right? There was a structural and historical and current reason why that happens. And the second sentence from WHO is really important for us to always say when we're talking about social determinants, because they didn't just pop out of the sky. God didn't make them. They didn't come from Jesus. This is really, we as people have created. These circumstances are shaped by the distribution of money, power, and resources at the global, national, and local levels. So the good news is we can make different decisions to not have inequities based upon where people are born, grow, live, work, and age. Next slide, please. And some examples of this is things during COVID have been really exacerbated, right? We know that Black, Brown, and Indigenous people are dying or getting the virus more frequently and are dying more frequently. And things like healthcare access. When you tell patients to go to your provider to get tested or to get the vaccine, that requires you to have had a provider of care. And a lot of folks do not, who are Black and Brown. They haven't even had access to health insurance, much less a provider that's their provider. The proximity to the hospital. Many of the hospitals, especially in rural America and Black communities, have closed. In urban communities, right? So proximity to care. We live in multi-generational household. That is a norm for most people of color. And then having pre-existing conditions. If you have never had access to healthcare coverage, like if you're in a state like Alabama, Mississippi, where they refuse, or Oklahoma, where you refuse to extend Medicaid, there are people for generations who wouldn't have access to a healthcare provider, who haven't had access to health insurance, who work every day, all day. So how would they know that they have diabetes? How would they know if they have a heart disease? They don't even have access to a provider to check them. So for them to know they have a pre-existing illness to avoid getting COVID implies that you've taken care of them enough to know that they have a pre-existing illness and that you've cared about their lives and their bodies and their ability to get services prior to COVID, which we as a country have not. Next slide, please. So some of the clinical barriers we've seen for maternity care since the pandemic is that some of the folks who are doing all this quality improvement, because of the uptick around talking about Black maternal health and talking about racism, there was a lot of quality improvement happening. And people had to shift those timelines. We know, as was mentioned, the Tulsa Birth Equity Initiative, doulas are critical to outcomes. Well, during COVID, it's been a barrier to get access to doulas, any kind of supports their birth workers. I mean, there were some hospitals not even allowing partners to come into the hospital during the pandemic. They were restricted entry, re-entry. It was not seen as essential to have a partner or someone there to social support. As we know, having a baby is not like having cataract surgery or your knee removed. It's a social event. It requires people, people want to have family members there, at least somebody. To have a baby alone is the loneliest thing. And we were making policy as if that was normal, that it didn't even matter if we didn't even have data to support why we should be doing it. We just told patients, you got to be in here by yourself to have this baby. That was our choice. That was the barrier we created. And then people are delaying care and getting infrequent postpartum checks because they're worried about catching COVID at the hospital or at the doctor or from their provider. And the providers are worried about the patients coming in. So all these barriers are going to see an increase in maternal health disparities and outcomes after the pandemic for sure. Next slide, please. So let's talk a little bit about race. As was mentioned, I work a lot on exchanging the word Black as a risk factor for the word racism. When I had my son, who's now 24, I was in medical school. I was married. I was intending to be pregnant. I was healthier than I am now. I was skinnier and exercising and ballerina and a cheerleader. And I still had him at 22 weeks pregnant. He weighed 445 grams. My only risk factor was being Black. And I thought there must be, because I was taught there must be something different about Black people. Something different. We have different vaginas or different cervixes, something biologically different that made me have my son early. Think about that. When you are talking to someone who has lung cancer, you don't say to them, oh, there must be something about you. You just got lung cancer, right? We know that smoking increases your risk of lung cancer. So we don't blame and shame the smoker and say, oh, well, smokers are all just going to just have to die, right? We look at cigarettes and say, how do we tax them? How do we tell people how bad they are? How do we ensure that people don't receive the harm from smoking, that we stop that? We can do the same thing when it comes to racism. We just have to recognize that there's nothing broken about Blackness and that racism is trying to kill us. Next slide, please. So race does not equal an ethnic group. It does not equal a population. It doesn't even equal ancestry. I am a 49-year-old Black woman sitting in a 49-year-old Black woman's body, but my race is not the same thing as my ancestry. My daughter did Ancestry 23andMe. I refused to do that. So it was funny because she said to me, she was so disappointed because she was only 55% of African descent. I said, well, thank God you were more than 50%. I don't know. I was a little worried what you were gonna be, right? But the truth is, none of us, no illness that I have has ever been blamed on my Irish ancestry. Everything comes from my African ancestry. This idea that my cervix, my uterus, my preterm birth, something must have happened in Africa, right? That comes from a deep-seated belief that people are broken just because of our skin color, and has a long history in eugenics and white supremacy culture that we have to end, because medicine and science were colonized by this belief that there is something different about the way our skulls are shaped, about our kidneys, about our lungs, and all that has never been facts. Next slide, please. Race is the physical differences that groups and cultures consider socially significant. So it depends on where you are. When I went to South Africa with my daughter, they kept telling me she was colored. Colored is not a word we use in the US context, but because she's lighter skinned than I, the locals told me they thought I was being not honest by not saying that she wasn't colored, right? Because it's a social construct and it's dependent on where you are. In New Orleans, growing up as a child, we know that there could be sisters. One marry a white man, one marry a black man. One raised their family as white, one raised their family as black. They have very different social outcomes, very different experiences in life. Their genes didn't change, their bodies and their biologies didn't change. It's just the characteristics that people considered socially significant said that they were white. Ethnicity doesn't have to do with skin color, but everything else. So it refers to a shared culture, such as language, ancestry, practices, and beliefs. So race is real and it matters in society, but not how racists think it does. Race is not biology, but racism has biological effects. So if I'm worried all day about my 10-year-old son playing outside with a toy gun, my heart's racing, my catecholamines are racing, my blood pressure is going to go up higher. Of course, I'm going to have higher rates of hypertension and heart disease because I'm always in fight or flight mode. I'm always nervous. I'm always waiting for something to happen. If we're going to end health inequities for Black people, we have to end the stress of racism on our bodies and the harm that that causes our cardiovascular system, our lungs, and everything else. Next slide, please. So it's racism, not race, that causes racial health inequities. Next slide, please. So then we have to have a common definition of racism, right? Because when I first started doing these talks, people would say, racism, oh, you're calling me a bad word. It's a bad name. Racism is not me calling you a bad name. I'm not blaming you or shaming you or saying you're a mean person. We have some concrete definitions that there have been for hundreds of years around the world, a hierarchy, a belief of a hierarchy of human value based upon skin color. And it was codified into laws, into policy, into cultural beliefs, and it still exists today. These are Kamara Jones's 3 levels of racism. She's the past president of the APHA and a mentor of mine. Next slide, please. So the first definition is institutionalized. And those are the structures, policies, practices, and norms resulting in differential access to the goods, services, and opportunities of societies by race. So an example of that would be Medicare and Medicaid, right? So they were founded in 1965. So where were we as a nation in 1965? Well, we know that we were very segregated at that time, trying to desegregate, but still very, by law, segregated. So for the Southern senators to agree to a healthcare benefit for poor people who they perceived to be Black, right? Poor equals Black in the Deep South and in the Mid and the Rust Belt. They said, okay, if we're going to agree to this benefit for health for poor people, then we have to control it. That can't just come from the federal government. It has to be a states' rights benefit. So to this day, Medicaid is governed by states. They dictate who gets it, how they get it, so much so that states like Michigan, when they were trying to do Medicaid expansion, voted it first to say that you only qualify for expansion in rural Michigan, no matter what. But in urban Michigan, you had to have a job. Who lives in urban Michigan? Black people, right? For Medicare, which you get after you retire from working at a job, is seen to be something for white people. So that's a federal benefit, so much so that the original Medicare excluded farmers and homemakers. Who else? Who was farmers and homemakers in 1965? Black people, right? That's who was cleaning houses and working on farms. So we racialize the benefit, a policy through the federal government where you see health inequities created by our choice to value one group of people over another. And it still happens today. Personally mediated is the biases and differential assumptions about the abilities, motives, and intentions of others by race. And that's what you think of when I say the word racism. That's you call me a bad name, the tiki torch, you're being mean to me. And that still happens. It happens in healthcare. It happens in hospitals and birth centers. People still have personally mediated racism, but it's not the overarching reason why we have health inequities in this country. And this last one, Kamara, is the big keynote, and I'm usually the afternoon delight. And back in 2017, right after the last election, we were both in San Francisco, and she was the big keynote, and I was in the afternoon. And she changed this definition for internalized. And although she hadn't changed it in her writings, I told her that I was going to change it in my slides when I talk about it because it rang so true for me when she said it. She said internalized was the acceptance. So we know this as Black people, that if you live in a place that devalues you, that says you're broken, you start to believe some of those messages. You start to accept them as truths. You start thinking, well, why doesn't my son play basketball? Don't all Black people play basketball? And I need to lighten my skin. And Black people spend so much money all around the world trying to lighten their skin or straighten their hair because we've been told being Black is dirty and bad and ugly. But it's also the acceptance of entitlement by the non-stigmatized group. And so that's what she added that she had not written down before. But for white Americans or white people around the world, the belief that you're supposed to have things because of whiteness makes you do things like vote against Obamacare because that's something for Black people, not for you. But yet your family members and your people of your state need access to healthcare coverage. They need Obamacare. They need, people are dying from substance use disorder, from chronic illnesses. And so this idea that Medicaid is only for Black people is killing white people. So racism is killing all of us. Unless you're a wealthy 1% landowning white man, the rest of us is killing. So until we can get rid of this hierarchy, we're all going to die in a way that we shouldn't. We're all harming all of our communities. It's not just for Black and brown communities to undo racism. It's clearly impacting all of us. Next slide. So when we found out that Black women were dying in childbirth at 3 to 4 times the rate of their white counterparts, and that the world was looking, the UN had a special commission. I was able to fly to Geneva, right? We said, oh my God, we have to get in front of this narrative. We have to get the data because they're going to say, of course, Black women are dying. They're so fat. They never listen. They're so non-compliant. They don't show up to their doctor's appointments. The same blaming and shaming that we did even during COVID, right? State senators saying things like, of course, people of color are getting more COVID. They're less hygienic, right? These biases and assumptions that have come from historical traumas are really important for us to undo and have real data and real facts. So when you looked at the data around maternal health, turns out for maternal and child health that Black mothers who are college educated fare worse than women of all other races who never finished high school in their MCH outcomes. Obese women of all races have better birth outcomes than Black women who are normal weight. So we're trying to do our little crunchies, do our little yoga. Y'all just did a little yoga. And we're still more likely to die, right? We're Serena Williams, best athlete in the world, still not listened to, still not heard, still almost dying in childbirth. Black women in the wealthiest neighborhoods do worse than white, Hispanic, and Asian mothers in the poorest ones. So we moved to the gated community. Racism follows us and it's like, I see you, sis, come on back here, right? And this last one is really hard for my fellow OBGYN colleagues because we love to believe we're the center of the world. And if you just came to your prenatal care, we could get you in the first trimester, everything else will be fixed if you just show up on time and do what we tell you to do. Turns out that African-American women who initiate prenatal care in the first trimester still had higher rates of infant mortality than non-Hispanic white women with late or no prenatal care. That's not to say that we shouldn't go to school or that we shouldn't do our little crunchies, that we should try to move into a nice house or that we shouldn't get prenatal care. We should do all those things. The fact is we do all those things. But even when we do all those things, this is our entire public health strategy. This is how we're going to fix birth outcomes for everybody. When we do all those things, we still have worse rates than white people. So the problem is not only to focus on those things. At some point, we're going to have to undo the racism that is killing us despite what we do as far as exercising and showing up. So that's what this work is for birth equity, to undo the structures that are harming us. There's some examples from data. We know that the data shows that our telomeres are shortened if you have life stress, and that Black women who are worried about racism have shorter telomeres. So there's a biological impact of racism. Next slide, please. We also know that the worry, this is from Paula Braveman at UCSF, the worry of discrimination, of racism, cause higher rates of preterm birth. That anxiety, that feeling of a heart racing that I talk about, if my son is outside playing, that increases your risk of preterm birth. So the answer is not to give me a pill to be less anxious. The answer is not to give me a shot so my heart doesn't race. The answer is to stop the racism. Next slide, please. We know that physicians who are Black, when they're paired with Black infants, have a 3 times more likely rate of having the baby survive. We know that segregation worked. People of different races don't know each other very well, especially white people knowing Black folks, right? And so it's important for us to think about, how do we have concordance? How do we get more Black doulas, Black midwives, Black nurses, Black OBGYNs? Because that concordance, that having racial concordance, actually saves lives. Next slide, please. We interviewed Black birthing people about their experience who had had an infant death across the United States, and what it looked like for them afterwards. Next slide. We looked at 50 different social determinants of health to see which ones had a positive predictive value for Black infant mortality. Push it again. These are the cities in the country that have the most Black infant deaths. The places that are red are where we interviewed, the red and blue are where we interviewed people. And the places that had the worst outcomes also had these higher rates of these social determinants of health. So things that you would expect, like if you have a higher rate of smoking in your community, you have a higher rate of infant mortality. Things you might not expect though, if you have a higher rate of pollution in your community, you have a higher rate of infant mortality for Black babies. So instead of just blaming and shaming the Black birthing people around why they don't put their baby alone back in a crib, because we don't provide access to heat or rodent control or all the things people need to feel safe, we could actually work on ending pollution in communities and have a better, higher rate of improving birth outcomes. So we could work on systems level change and not continuously blaming and shaming individual behavior. Next slide, please. So racism and bias are baked into our policy. They were policy, they are policy. They're the belief that some people should have and they look a certain way and some people should not. And that's been in our policy for a very long time. Next slide. So the language matters. When I was in medical school, my embryology teacher said there were 3 races: Mongoloid, Caucasoid, and Negroid. He was talking about skin types. Right, so we've been teaching this. This is in the 1990s, this idea of a biological basis of race and biological skin. So we no longer say Negroid. In fact, we organized to get him fired when he said that back in the 90s. And I remember him being so stunned and upset. He was like, of course, this is science. I've been teaching this. You've been teaching pseudoscience. There's no biological basis of race. So we no longer say Negroid. People who are of Asian descent don't say Mongoloid, but white folks still say Caucasian, right? So we even have to unpack, why is that? Well, the term Caucasian has been used as a politer way to say white. Although it's outdated and it's geographically incorrect, in fact, there is a Caucasus Mountains and they're having a war right now. And it has nothing to do with white supremacy, right? So this idea of Caucasian and whiteness was made up. It was coined in the late 18th century. And it was to prove that Caucasians were superior to other races. And it was used to execute discriminatory immigration laws, to justify slavery, and the field of eugenics. Next slide, please. We also talked about reproductive justice. We can't talk about reproductive justice without talking about reproductive injustice. The top picture is Anarcha. So the founding father of gynecology, my field, obstetrics and gynecology, J. Marion Sims, was a plantation doctor. He worked on a plantation. The transatlantic slave trade had ended. It was no longer legal to import slaves from the continent of Africa, but slavery was still legal in this country. So the major economic engine for this country were the uteruses of Black women. That was a major market. That was what made money for people, made people very wealthy. And so they wanted to ensure, just like people go to the continent now to go do fistula repairs, that was happening right here in the United States. And the goal was to ensure that the Black women who were birthing babies to become enslaved and to be owned could be sewn back up so they could have more babies. So that's where the Sims retractor comes from. And he also did these surgeries without any anesthesia, even though anesthesia was available at the time in this country. And he said, well, they didn't need it because they didn't feel pain. And he wrote that in textbooks. And today, there are still medical students who were asked, and they believe that Black people don't feel pain the same way that white people do. They believe that we have thicker skin. All of these racist ideas come from a history and legacy of eugenics and white supremacy. My own university, Tulane, where I trained in medical school in residency, there was a Dr. Cartwright who had a disease called drapetomania. If a slave looked you in the eye, you could give him more lashes. If he tried to escape, you could cut off a toe. So once again, medicine was colonized by white supremacy. This idea that you make an illness out of wanting to be free, you put it in a textbook, and then you have treatments for it. Beating a person, putting it out in the sun, cutting off a toe. That's not science, right? That's being colonized by racism. We also know this history of eugenics and family planning, this idea that if only you just plan better, the rest of your life would be fine without investing in things like equal pay, paid leave, is very problematic still today. Next slide, please. So this history of contraception is so important for us to unpack, and how we get to this term family planning, who has the right to have children and not, who's believed, who's valued, whose reproduction who is valued. Right? You have a term called stratified reproduction, who's supposed to have children and who's not. So even since the 19th century, Black women have been limiting their family size to defeat white supremacy, trying really hard, taking herbs, doing anything to say we are not going to just have our babies sold into slavery. Back in the 20th century, the first family planning clinics popped up. And even back in 1965, white women had to be married and have permission of their husbands to get birth control. So this idea of both gender oppression, right? This idea that a woman is hysterical, hence hysterectomy, that you had to have your husband's permission, so you had to be married. You can't get on birth control if you're a loose woman. You know, wild uteruses just running out here all trying to have sex and be wild and loose, right? We're not that far. When we try to blame and shame countries who do things like genital mutilation, we are not being honest about our own history in the United States. We're acting as if we've been so forward thinking, and yet we've had these laws for a very long time that required people to have permission just to get birth control pill of their husbands. Next slide, please. In 1970, President Nixon established the Office of Economic Opportunity. And to get economic opportunity for Black and brown people, he said it would be through family planning. So imagine that. Imagine that if in 1970, instead of saying the way to economic freedom for Black and brown communities is through the uteruses of Black and brown people, as long as they don't have babies, they will be economically free. If he in 1970 had, I don't know, gun free college for Black and brown people, we might not be so broke. There might have been some economic opportunity, but this idea still across the world that if people just had fewer babies, that they would have more money. This even tying climate change today to the uteruses of people in poor countries, when we know that's just factually not true. We have climate problems because of rich rich companies in high income countries, not because a poor woman in India is having a baby. But that's the way we frame our family planning, still looking for this eugenics and looking at the uteruses of poor women across the world as our way to economic freedom. It's easier to punch down. It's easier to punch the people who have the least power and say, oh, just stop having all those babies, versus actually working with the companies who are polluting our oceans, who are polluting our air, and telling them to stop. Next slide, please. African American women have always fought for self-determination of their bodies. I brought up the reproductive justice movement, but be clear, since we've come to this country, we've always been fighting for our own freedom. We've always opposed this idea that if we just planned better, our lives would be better. And these ideals of race-based eugenics still contaminate the thinking around reproductive rights for African American women. Just the border, just this year, doing hysterectomies, doing surgeries on women without permission, that's still a devaluation. And when the Black maternal health crisis was first announced, many states, their response to the fact that Black women were dying in childbirth was to increase their LARCs and IUDs to the Black community. Not to say we invest in you, we want you to have economic freedom. It was once again to say, well, just don't have any babies, right? So when are we going to invest in people to thrive and to have well-being and to be supported, no matter their skin color, no matter their religion, no matter their class? Next slide, please. The use of birth control became a right or an option for white women, while it became viewed as a necessary obligation for poor women, particularly women of color. So really think about that when you're doing your work around birth control and birth equity. Are you asking poor women and women of color to be obligated to use birth control and not investing in their ability to have well-being and freedom? And when would they get off the birth? When would they be okay enough to answer yes to intending to be pregnant? What are you doing to invest in their ability to have justice and joy? Next slide, please. So reproductive oppression is the control and exploitation of women, girls, and individuals through our bodies, sexuality, labor, and reproduction. The regulation of women and individuals thus becomes a powerful strategic pathway to controlling entire communities, right? Nixon, global family planning. It involves systems of oppression that are based on race, ability, class, gender, sexuality, age, and immigration status. Next slide, please. Access to contraception, targeted sterilization, and abortion practices are all parts and tools of reproductive oppression. Next slide, please. You know, when I was a resident, we didn't have an illness for crack mothers who were substance using crack. They were just crack mamas and crack babies, right? Illicit drug use, although it was equally as prevalent in white women, it was thought to be something that only Black mamas do, right? It connotated careless Black motherhood of inner city America. There were crack babies were considered to be biologically inferior. They were going to be eventual super predators. That came from the highest office, right? The first lady said, they're these super predators. We got to do something about these drugs. Federal assistance, they were going to be a long-term burden on federal assistance. Pregnant drug users were convicted as killers, as drug dealers, and child abusers. Some are still in jail today, 30 years later. Mass incarceration of Black mothers through random drug testing, through leveraging and child removal and incarceration. Now let's think about today. White women are America's sisters and daughters. Opioids are an epidemic of despair for middle America. It's considered a disease and not a moral failing. There have been no conclusion that babies are being born right now will be a long-term burden on society. There's been a public health response under the previous administration who didn't invest in public health, $45 billion though for opioids, right? And the southern states that led in criminalizing Black women who are still in jail today are softening those punishments and policies right now, right? West Virginia has a separate NICU so that mothers and babies who are detoxing from opioids can have low lighting, they can sleep in, that they know that the bond between the mother and the baby is so important. And they want to make sure that the mother takes home her biological child. Just close your eyes and imagine what the world would be like if in the 1990s we had believed that we need to put that much interest in ensuring that a Black mother took home her biological child who was crack addicted. We wouldn't be here today when it comes to the opioid epidemic, because we would have created a system of care, of caring, of understanding what to do with substance use disorder so that we would be prepared for the crisis that we have today. It is not bad that we care around the opioid epidemic today. It's exciting and great, but we wouldn't be here if we hadn't racialized the epidemic 30 years ago and blamed and shamed people and put them in jail. Because all you do when you blame and shame one group is it comes back to bite you in the end, because now we're here and we're having to create a system that we should have created a long time ago when it comes to substance use disorder and valuing everyone equally. Next slide, please. And we learned from this lesson. We learned that there was no such thing as a crack baby, that these people are now doctors, lawyers, and Indian chiefs, right? They're running around, running the world, people who were born addicted to crack cocaine. And this not actually talking to community. So this was an assumption, this was a bias of the researchers that this was going to happen, but it didn't happen. So understanding community context is really important. When the thing that causes harm was not the crack, it was taking the children away, the separation, the not having contact, right? So having data with no voice creates poor policy. Criminalizing people who are substance using is a poor policy. And when you create that policy without having the community who are involved, you're going to have the bad outcomes that we had and continue to have today. Next slide, please. So what are some strategies that we can do to move forward? I'm not all bad news, right? We got some good news. We got some ideas. Next slide, please. So first is to have a racial equity lens, because we know that healthcare systems alone aren't equipped to overcome the inequities driven by income, language, education, or racism. So having a racial equity lens requires us to center place, environment, and social determinants, to address aggravated risk, and to address intergenerational and cumulative effects of structural racism on our health. Next slide, please. My favorite book is Ibram Kendi's Stamped from the Beginning, The Definitive History of Racist Ideas in America. And it's a very thick book, but it's an amazing book. And in it, he won the American Book Award for it. He's also written How to Be an Anti-Racist. There's How to Be a Baby Anti-Racist, and there's a anti-racist for high school students. So it's a whole theme. He has the Center for Anti-Racism at Boston University. He used to be at American University, and I got to work with him quite a bit when he was here in DC. And people would ask him, what came first, racist policies or racist ideas? Chicken, egg, right? Like, how does this work? And he would say that individuals, use racist ideas to hoard power and wealth. So power and wealth balances create racist policies. And then racist policies create health disparities. And so these past political actions can be undone if we come together with deliberate anti-racist action moving forward. You can't use race neutral policies to undo generations of racist policies. We can't say, oh, okay, well, we're over that now. We're moving on to the next thing. We have not undone the harm that was created by discrimination for generations. So racial discriminatory policies are usually sprung from individuals having self-interest. And those self-interests are constantly draining, economic, political, and cultural. What we have is collective interest that's much bigger than self-interest. So as long as we can agree that our job is really to hold people accountable who have power and wealth and who are using racism as a tool to hoard more of it, while we're all not getting access to healthcare, not getting access to transportation, not getting access to good jobs, we're all losing. They're winning, right? And we're over here fighting each other about calling each other names. This is so much bigger than name calling. This is about policy, about strategy, and undoing the harms of a legacy of white supremacy culture. Next slide, please. So when you have a reproductive justice lens for family planning, you can think about this Maslow's hierarchy of needs, right? So if you're only thinking about self-actualization, my choice, my body, right? We hear a lot of that language. I want it, I, right? So that's self-actualization. Esteem needs, people want recognition. And then we also want loving and belonging. So that's really where we a lot of times talk about this work that we all do together around contraception, abortion access, family planning. Next slide, please. But if you have a reproductive justice framework, you understand that people are motivated to really make decisions about their entire list. So they have safety needs. I talked about being able to parent in a safe and sustainable community. If you're only talking to your patients about IUDs and they're worried about being shot in their neighborhood, they don't think you're a very good provider. You're not listening to what their actual needs are. You're only living in what your biases say about what their needs should be. And then their physiological needs, things like clean water, clean air, having access to transportation, clean food, right? So that is part of family planning. It's not just giving somebody an IUD and saying, oh, I don't care that there's not actually a grocery store in your community that has fresh fruits and vegetables. Family planning and reproductive justice means you care about all of that as a community. Next slide, please. There was a campaign. I mentioned that, when the first Black maternal health crisis came out, the first response was, oh, we just give them all larks, right? We like to give people things, Black folks used to breastfeed other people's children. Then when formula came out, they loved selling stuff through the government to Black people. So we became the recipients of all this formula. And we went from not only not breastfeeding our own children and not breastfeeding other people's children to not breastfeeding at all, right? So the same thing happens when we say it's a maternal health crisis. Instead of investing in equal pay, paid leave, access to healthcare services, just give us a bunch of IUDs. That's what the answer will be. So maybe an IUD was a public awareness campaign. And the community fought back. And what the community said is that is really concerned about the stigma and the shame and the coercion. And so they really said, we want to have a sexual and reproductive justice community engagement group, provide formal feedback to your health department to help align with sexual and reproductive justice, ensure ongoing community input into what happens with our public resources through the public health department, through any public awareness campaign or advocacy campaign, and then plan and implement activities. They created a respectful maternity care standards for the hospitals that we're now working with them to implement in the hospitals across New York City. This all came about because it started with blaming and shaming the community around IUDs as the answer versus investing in respectful maternity care. Next slide, please. We asked the current administration before we even knew who it would be, back when they were all campaigning, we didn't even know who would be the president. We created a birth equity agenda. What would the future look like? Whoever's going to be in office in January. And now we're here, and it's almost March. And we asked for 5 critical measures for ensuring the United States has the proper infrastructure and resources to achieve equitable maternal health outcomes. Reproductive health and autonomy are promoted at the highest levels of government. So we want a White House level office of reproductive and sexual well-being. Health is a governmental priority and should be recognized as a right. So that doesn't mean single payer. We haven't even agreed that everybody is deserving of health. Can we just start with that as a country, as a community, agreeing no one should not have access to health? And that doesn't necessarily mean healthcare coverage only. That means all the things that allow for you to be healthy. Individuals and institutions are held accountable for discrimination that leads to disparate health impacts. We've learned from our colleagues in the police field that just because you train somebody in implicit bias, if there's no accountability, then they can just stay at their work and check off that they've done that box. So whatever you build in Tulsa or anywhere else, ensure that there is a mechanism for accountability. No maternal death goes unnoticed and uncounted. We did not have up until last year official count from the US government on maternal deaths since 2007. You don't value what you don't count. That's a long time for not counting maternal deaths. So no deaths should be uncounted. And the government's involvement in reproductive health may not intrude on reproductive freedom, agency, and autonomy. It's not their job to tell us how we should plan or who should have babies or who's deserving of reproduction. It's really ensuring that we have freedom and agency. Next slide, please. And so looking at with the Momnibus, the Black Maternal Health, and now there's the Act of 2021. So I have to update my slide. And we've added 3 more things about data and COVID. But really, this was really important because it came from Black birthing people. It was for the first time, I'm involved with a lot of congressional bills. This is the only one where they came to us first and said, you tell us what's needed. So it's everything from justice for incarcerated moms, to ensuring that people who are in the workforce, the social determinants are impacted, that moms who are in the military have access. All that is included in this Momnibus. Next slide, please. We know that we are not getting the data. The data must be disaggregated by race. I'm hoping that in Oklahoma, you all are disaggregating your data by race because we need to have our resources that are targeted to the communities that need them. Next slide, please. And some alternatives. This is from Scientific American, my colleague, Dr. Monica McLemore, and setting up telehealth doula services, offering food vouchers and meal delivery services, investing in home birth and birth centers to expand and maintain their current services. We also know that it's important to prioritize COVID testing, and we really want to permanently expand Medicaid coverage postpartum for up to 1 year. Next slide, please. Respectful maternity care, push it again. So globally, there's a standard for respectful maternity care. It was put together by USAID, WHO, White Ribbon Alliance, with researchers and practitioners, advocates, and policymakers. Next slide, please. And the New York City Standard for Respectful Maternity Care that I mentioned already was built upon this. It believes that a birth asserts that it's safe and that the birthing experience is a human right. And the ultimate goal is to promote health equity by fostering an environment where patients feel empowered to assert their rights and to advocate for themselves, where providers listen and trust their patients, and providers and patients work as a team to make joint decisions. Next slide, please. This is our Mother Voices Driving Birth Equity. It's funded through the Robert Wood Johnson Foundation. The American College of OBGYN and Johns Hopkins School of Public Health are our subcontractors. We interview Black birthing people around what respectful maternity care, which is a global concept, what would it look like for the people who are the most impacted in a high-income country like the United States, Black birthing people? What are the things, how do we trust and listen to Black women? How do we have a reproductive justice, cultural humility, and research justice framework for building the next iteration of what health should look like for birthing people in the United States? Next slide, please. We interviewed Black birthing people in these cities. Next slide. These are the themes that they told us. They want accountability. They want empathy. They want safety. They want trust, and not trust in the way that we talk about trust in the healthcare system, trust in the way that patients want. They want us to trust them. We talk about them trusting us all the time, but do we trust patients? Every time you write the word non-compliant, do you trust the patient? Do you value them? What if you couldn't write that word? What if you had to actually figure out what's happening in their lives? right? So trust goes both ways. Next slide, please. This is the cycle to respectful care. We submitted it for publication, so hopefully it'll be published soon. But at the core, it's really valuing Blackness, right? Because it's been devalued for so long. Next slide, please. This is the black paper, we wrote a black paper, not a white paper. It's on the Black Mamas Matter Alliance website, setting the standard for holistic care of and for Black women, really having trauma-informed story sharing, community-informed advocacy. Next slide, please. What is missing from the care of Black women is their centered voice, validation of experience, and freedom to choose and be informed. Black women need respectful care that is free of implicit and explicit bias. It is the provider's responsibility to address those biases. To address the issues of maternal mortality, we need care that originates from and is defined by Black women-led organizations, practitioners, and community members. This is my co-chair of the Black Mamas Matter Alliance Care Working Group. She's a nurse who's also a doula, who's also a public health, and leads Root, which is in Columbus, Ohio. Next slide, please. This is our decolonizing research paper. It's in the Harvard Law Review, which I actually have a copy of right here. And the principles for conducting research with and for by Black mamas. And number one is investing in Black women as researchers and scholars. We're not just here to get your $24 gift card if you can ask us questions. We actually are researchers and should be leading research, so important to start there. Next slide, please. This is my last slide. This comes from Ibram Kendi's book. He separates folks out as segregationists, assimilationists, and anti-racist. And he follows several people in the book. He follows President Washington, President Lincoln, Angela Davis. The story I want to tell today is about his story about President Lincoln. It's really important for us as we think about our work going forward, because President Lincoln, for a Black person in America, 7 generations at least of US-born American Black person, love President Lincoln, right? Free the slaves, yes, very important. But clearly he was a complicated man. So near the end of his pregnancy, Lord have mercy, near the end of his presidency, he invited 5 Black leaders to the White House. 5 Black men get to go to the White House, and they're all excited, like, yes, we're winning. We're going to the White House. We're going to talk to our boy. So they get there, and he's like, hey, guys, listen, the war is almost over. I have a few $1 million. Why don't you take your people and go back to Liberia? And if not Liberia, you can go to Panama. I don't really care, one or the other, because we need to move on with our white nation here in the United States. So Black or brown place, just leave. And so the Black people said, I don't think so. We've been here for 250 years building all this for free. We think we want to stay. We're good. And his response is what's so important for all of you at this moment as you think about your journey to undo racism and health. Abraham Lincoln's response was, but guys, you're being so selfish. If you would just leave, the war would end and we could move on. Because the truth was, although Abraham Lincoln is a good and kind man and a moral man who believed slavery was bad, he also believed that Black people were broken and we had done our job and it was time for us to go back to our own land. So he was a segregationist, right? If you believe that we need to be closer to white folks so we can act less Black and get along better, then you're a assimilationist. What we want you to be is actively anti-racist. We want you to understand there's nothing broken about us. We don't need to move back to Africa. We don't need to get closer to white folks to do better, that we're all one people. There's no genetic basis of race. God didn't put us on different continents so we wouldn't mix, that we're all equal and we're all fighting for justice and joy for all. And that is it. Next slide. Hope I left time for a few questions.
Hi, Dr. Joia Perry. Thank you so much for not just giving us history and context and breakdowns of frameworks. That was just such rich information. And I know people in the chat were really just excited and things were really resonating with them. I know we're a bit over time, folks, but if people we can do 1 or 2 questions, if that's okay with you, Dr. Crear.
Yeah, I thought I was supposed to do an hour and 15 minutes, so I'm fine.
Oh no, you're good. And what is time? What is time anyway in the land of
exactly.
Which I know. I'll give folks a second. Just want to see if there are any raised hands first. I know we had someone in the chat asking if they had a question. Here we go. Brandy, did you want to unmute Kimberly? I know she had a question. Oh, can we do Corinna first because her question had come up earlier? Yeah, Brandy, if you could unmute Corinna so she can ask her question. If you don't mind, don't worry, Corinna, your video won't pop up, but we'll get to hear you asking if that's okay. Let's see, just giving it, sorry.
Hey guys, I'm looking for Corinna. I'm so sorry.
Oh, no worries. It's Corrina.
There she is. All right, Corinna, you are good to unmute.
Thank you so much, Dr. Joy. I just want to ask one question. I am just now starting to see more funders get Black health needs research, and we need to, it's almost like we're the forgotten race.
Yeah.
Just even with my grant, which is, of course, Healthy Start, I was elated to see that the feds are trying their best to put it in contents where we can apply for, more funding as it relates to like the Black doulas. Are you seeing that as well? Because I don't want to just say that and I'm actually, nobody else is seeing it, but I'm starting to really see that people are starting to really take notice of it. I'm just afraid that the ones who need to take notice on it are not on board.
Well, I love my Healthy Start family, so thank
Yes.
you. Right? But yeah, it is definitely I could say my own organization, we've quadrupled in size in the last 6 months. So right now it's all sexy and everybody's like super into it. George Floyd, the murder of George Floyd, the murder of Breonna Taylor, it is the thing to do. What we want to figure out though is how to make it sustainable. I worry not so much that people aren't doing it. I worry that they just want to say that they've checked off a box and they've done it and they move forward. So how do we make this the new way? That this is not just a flash in the pan and a response to an uptick of violence, but really we understand for real that we have to reallocate funding and invest in the communities that are the most impacted. And the example I give is that the hospital where I trained in Louisiana was named Confederate General, but not until 1956, which was almost 100 years after the Confederacy lost. So they named it that for a reason at that point, right? Because that was the beginning of the civil rights movement. So if we don't ensure that this is a prolonged conversation, that we're not just having this one conversation at the end, because there's an outbreak, you're going to see, if not 80 years from now or 90 years from now, 8 years from now, a retrenchment and a backlash. So that's that long-term commitment to have equity means forever, always ensuring that the people who are the most impacted get access to resource.